surgical management. Okay, so first we are going to discuss Crohn's disease. What all are the indications of surgery in Crohn's disease? As we all know, Crohn's disease involves both small intestine and large intestine. So if there is a Crohn's disease of small intestine, then if there is development of stricture, intestinal obstruction, which is not responding to which is not responsive to the medical management, non-responsive to medical management. Okay, then we are going to perform surgery. If there is massive hemorrhage, if there is a refractory fistula or intra-abdominal abscess. Okay, similarly in large intestine, if there is intractable or fulminant disease, if the disease is not responding to the management, or if the disease is very severe or is life-threatening. Okay, if there is a perianal disease which is unresponsive to medical management, if there is a refractory fistula, if there is a colonic obstruction, or there is development of dysplasia or malignancy. So these are the indications for surgery in Crohn's disease. So in Crohn's disease of small intestine or large intestine, we are going to remove only that particular portion of the intestine that is causing the problem. Okay, and that is responsible for the current problem. We are not going to remove whole of the large intestine as we are doing in ulcerative colitis. In cases of ulcerative colitis, we generally go for a total colectomy or a total proctocolectomy or a subtotal colectomy, whereas because it is a continuous disease in ulcerative colitis, whereas in Crohn's disease, as it is a there are skip lesions, and we generally remove only the involved portion or the portion which is causing the current problem. Okay, so Crohn's disease of small intestine, there is a possibility of having multiple small bowel resection and anastomosis. Patient may land up into small, you can say in a short bowel syndrome later on, but at that moment of time, we are only going to remove that particular portion in which there is a stricture or from which there is a bleeding or in which there is development of a malignancy. Okay, so that is about Crohn's disease. Now, what all are the indications of surgery in ulcerative colitis? Intractable disease or not responding to medical management, intractability, development of a dysplasia or malignancy, if there is a massive colonic bleeding, or if there is development of a toxic megacolon. These are the indications for surgery in ulcerative colitis. Okay. Generally, the dysplasia or malignancy, it is associated with the duration of duration of the disease and extent of the disease. Okay. More the duration of the disease, more chances of developing a malignancy. More the extent of the disease, more chances of developing a malignancy. Now, what all are the surgical options in ulcerative colitis? In Crohn's disease, there is resection and anastomosis, whereas in ulcerative colitis, the most preferred surgery or the treatment of choice is total proctocolectomy with ileal pouch anal anastomosis. Ileal pouch anal anastomosis. Now, what is this total proctocolectomy and ileal pouch anal anastomosis? This is colon, this is terminal ileum, this is rectum, this is anal canal. Okay. We are going to remove whole of the colon and whole of the rectum till the dentate line. So we are left with a terminal ileum and anal canal, and we have to join ileum and anal canal here. But now we have removed the rectum also, so the reservoir is not there, and in case if we are joining this ileum along with this anal canal directly, then there will be loose motions, there is no reservoir. So that is why we are creating a pouch, which is a J pouch, and this J pouch is acting as a reservoir, and we are anastomosing this with the anal canal. So whatever amount of liquid is coming from the small intestine, it gets collected in the ileal pouch, and then it is being released later on from the anal canal. So this J pouch acts as a reservoir in place of a rectum after total proctocolectomy with ileal pouch anal anastomosis. Apart from this total proctocolectomy with ileal pouch anal anastomosis, there are other options also. So the surgical option first is total proctocolectomy. First is total proctocolectomy with ileal pouch anal anastomosis. Which pouch? J pouch is preferred, and this is the definitive treatment. Other options are total proctocolectomy with end ileostomy. So that is end ileostomy or a permanent ileostomy. Next is a total proctocolectomy with continent ileal reservoir, which is also known as a Cox pouch. We are not making an ileostomy, but we are making a reservoir from the abdomen. Patient is putting a catheter inside, and whatever liquid is collected in that reservoir, it comes outside. As such, there is no ileostomy, but it is similar to ileostomy. Rather than creating ileostomy, we are creating a reservoir in the abdomen, close to the abdominal wall. Okay. Then we can also perform total abdominal colectomy with end ileostomy, and or a subtotal colectomy with end ileostomy. This is generally performed in patients with acute flare or with toxic megacolon, or if the disease is intractable, then we generally don't go for a single stage total proctocolectomy with end ileostomy. We firstly do a total abdominal colectomy with end ileostomy, and suppose this is a problem, this is rectum. If there is a lot of inflammation here, what we do, we generally do a Hartmann closure here, and we remove whole of the colon. Then we are making ileostomy. Later on in the second stage, initially we are doing total abdominal colectomy with end ileostomy with a Hartmann closure. Hartmann's. Then in the second stage, we do a completion proctectomy. We remove the rectum. With ileal pouch anal anastomosis. we can do it with a divergent ileostomy or without a divergent ileostomy, and then in the next stage we have to close that ileostomy. Okay, so that is mainly done in emergency cases, and in routine cases the preferred treatment is total proctocolectomy with ileal pouch anal anastomosis. So now this ileal pouch anal anastomosis, there are three types of pouch. There can be J pouch, there can be S pouch, or a W pouch. J pouch is the most preferred. So if there is a young patient with no dysplasia or malignancy, then we are going to prefer total proctocolectomy with ileal pouch anal anastomosis. Okay, in presence of rectal dysplasias, we generally don't do ileal pouch anal anastomosis. If there is rectal dysplasia, we generally prefer total proctocolectomy with end ileostomy. Either a rectal dysplasia or a malignancy. Generally don't perform ileal pouch anal anastomosis. Okay. Now we have performed a total proctocolectomy with ileal pouch anal anastomosis. After surgery, what is the most common complication in ulcerative colitis? Most common complication. So the most common complication is pouchitis. That inflammation can extend to the pouch also, which is pouchitis. Then the patient will present with bleeding per rectum, increased frequency of motion, may develop fever. Okay. After pouchitis, the second most common complication is small bowel obstruction. Small bowel obstruction. The small bowel obstruction is generally seen in 25% cases. This pouchitis is seen in 7 to 33% cases. Okay. Now, what is the treatment of choice in familial adenomatous polyposis? It is total proctocolectomy with ileal pouch anal anastomosis. In familial adenomatous polyposis, as it is not an inflammatory syndrome or disorder, here the most common complication after surgery is small bowel obstruction. The small bowel obstruction seen in 25% cases. Pouchitis is not seen or is not common. In FAB. Okay. Now, if we say here what all are the complications, most common is pouchitis. Second most common is the small bowel obstruction. This pouchitis is 7 to 33%. The small bowel obstruction is in 25%. Others can be pelvic sepsis, which may be because of leak, or there is a possibility of pouch vaginal fistula. Okay, this is very important. Ileal pouch anal anastomosis is contraindicated in Crohn's colitis. Okay, if there is severe or fulminant Crohn's colitis, we are going to perform total colectomy with end ileostomy or ileorectal anastomosis, but we are not going to perform ileal pouch anal anastomosis because there is increased possibility of development of a pouch vaginal fistula later on or a fistula later on. So it is ileal pouch anal anastomosis is contraindicated in Crohn's disease. Okay, this is important. Now there is a special situation. Now there is old patient with fecal incontinence. Suppose there is old patient with fecal incontinence with a poor anal tone, then we are going to perform in ulcerative colitis, we are going to perform total proctocolectomy with end ileostomy. if there is presence of rectal dysplasia, then either we can perform total proctocolectomy with endoleostomy, or we can do total proctocolectomy with mucosectomy with the hand sewn ileal pouch, anal anastomosis. We'll remove whole of the mucosa above the dentate line, and because with the stapled approach it is very difficult to remove whole of the mucosa, there is some rectal mucosa which is left. That is why mucosectomy with hand sewn IPAA can be performed in cases of rectal dysplasia. In cases of rectal malignancy, this mucosectomy with hand sewn IPAA is not performed. Generally, total proctocolectomy with endoleostomy is performed. Okay. Now, if a patient is a poor operative candidate, performing a rectal surgery and performing a pouch is very difficult and is not feasible. Best procedure will be to perform a total abdominal colectomy with Hartmann's closure with endoleostomy. And the remaining rectum we can manage with the you can say the local therapy or the 5-ASA agents or the enemas we can manage. Okay.